Bismillahirrahmanirrahim. Hi everyone. This is the second video about abdominal pain, and this one we're gonna go by quadrant and talk about some of the common causes of abdominal pain and how to diagnose them by guidelines and imaging that are mostly useful. And at the end, we're going to talk about a little bit less common causes of abdominal pain. Most of the causes we're going to talk about are the ones that can relatively be easier detected by imaging, including CT scan. And statistically also, they're probably the most common causes of abdominal pain in general. So before we jump in, let's really quickly talk about the visceral pain, the parietal pain, and the referred pain. I think it's important to understand these basic principles so that you can have an idea about the pathophysiology of most of these causes of abdominal pain. And you have probably encountered these before, so we're just going to talk about them really quick. So for the visceral pain, there are basically two stimuli for that. There's mechanical stimuli and there's chemical stimuli. Mechanical stimuli, for the classic example, is bowel obstruction, for example. So this type of pain is being usually started with stretching, which is a really potent stimulus, or torsion or contraction of the organ. And the chemical stimuli basically happens with inflammation or infection, for example, and usually due to many substances, including substance B, serotonin, prostaglandins, and hydrogen ion that you usually see in acidosis, for example. And it's usually described as crampy or dull or achy, so kind of a vague type of pain. And that's because it's conducted through the slow conducting C fibers. And it's usually nauseating, usually accompanied by nausea, but can really be severe at times. And it can be either steady and constant, or sometimes can be intermittent. And that's what people describe as colicky abdominal pain. And then another characteristic of that visceral pain is, remember that the intraperitoneal organs, they're usually bilaterally innervated, so that the pain is felt in the midline. The body, the brain, will perceive the pain coming from generally the midline, and that's specifically true for diseases associated with the small bowel or large bowel. So you'll see that in the mostly on the midline, close to the center. Now, referred pain. So it's basically pain that is felt in a location distant from the diseased organ. And that's based on the developmental embryology and segmental innervation of that organ. And of course, the classical example include the stone pain in the ureter, can be referred to the testes, and gallbladder disease like acute cholecystitis. Sometimes the patient might feel that in the shoulder. And another character of referred pain is that it's usually perceived on the same side as involved organ. So in acute cholecystitis, for example, it's usually the right shoulder. If the stone is in the left ureter, then the pain is usually left in the left groin and left testicle and so forth. Now compare that to the parietal or somatic pain. That's usually typically sharp pain and well localized. And that's because it's conducted through the rapidly conducting A delta fibers. So the brain can perceive exactly where the pain is coming from. And it usually results from a direct irritation of the peritoneal lining, so usually as a result of localized peritonitis. And it's similar to musculoskeletal pain, so it's worse with movement and cough. So that has some diagnostic significance. And of course, the classic example between visceral and somatic or parietal pain is I want to talk about acute appendicitis and how the pain usually is in the center, periumbilical vague, and then it shifts to the right lower quadrant because of the local peritonitis. Now, these patterns are very useful and helpful, but remember, unfortunately, this pattern matching is only typical for the diseases in only 67% of cases. So sometimes, like the case we talked about in the first video, patient with acute cholecystitis, the pain might not be very classic or very typical. So you have to be mindful about that so that you don't miss important diagnosis, because this can be common sometimes. Okay, so we are going to start with one of the common areas for a source of abdominal pain, which is the right upper quadrant and the right flank pain. So organs you have to think about when someone presents with pain in that area, there are many, of course, right? Including the hepatobiliary system, probably the most common, the liver, the gallbladder, the bile duct, the antrum of the stomach, the duodenum and the small bowel, the head of the pancreas, the neck of the pancreas, the large bowel, specifically the hepatic flexure and the surrounding colon, the right kidney, also relatively common, the base of the right lung, the right lower thoracic cage, including the intercostal muscles and ribs in that area, the lumbar and back muscles in the right lowing areas. Patient with lower abdominal pain, if it's mostly in the right side, they might present with like what look like right kidney problems. And then the other structure that are actually not only for the right upper quadrant, but also all the other quadrants in the abdomen. These are the structure that frequently forgotten and could be a source of pain, including the peritoneum, the skin and soft tissue and muscles. A very common example is patient with cough because of upper respiratory viral infections, for example. Because of the repeated cough, they might have some upper abdominal pain, not just in the right but also on the left, and it's just from the chronic contractions of these muscles because of the coughing. And they might actually tell you like what it's like in the right upper abdomen. They usually felt it in the right upper abdomen, and it's actually painful to move the abdomen sometimes. So keep that in mind. And then the neurovascular bundle in that area too, including the nerves, the veins, and the arteries, could be a source of pain as well. A lot of conditions can present with acute pain in that area, but probably the biliary system, including acute cholecystitis and the biliary colic, is probably the most common. But other pathologies like cholangitis, frequently encountered. It's serious but less common. Hepatitis, also relatively common. It could be from various causes. Maybe we can talk about that in a separate video. Spacing cubital lesion in the liver, including liver abscess, liver tumors, liver cyst, or any mass in the liver. Pyelonephritis, right kidney infection, and other right kidney disease. Also, like kidney stones, could be also a source of pain in that area. Right lower lobe pneumonia. This is some of the causes outside of the abdomen, and also pulmonary embolism in the right lower lung. So these are just some of the sensitive and hopefully specific diagnostic test, imaging test that you can order. As you can see, ultrasound is relatively a good test to start with in patients who present with right upper quadrant abdominal pain. It can help specifically for the hepatobiliary system. Very useful, so start with that. But of course, other tests might be needed, like liver function tests and liver enzymes in hepatitis. CT scan if you need more details in certain pathologies like masses, tumors, abscesses, and all that. And then also, if you need more details, suspecting more complicated pyelonephritis, you might need a CT scan. And of course, you need some other extra abdominal imaging to make some diagnosis, like in right lower lobe pneumonia. Starting with a chest X-ray is good, but sometimes you might need ultrasound and CT scan. They're more sensitive. And then for pulmonary embolism, you might need a CT PA. So that's mostly what you're gonna see in the right upper quadrant and right lowing pain. Now, briefly about one of the most common causes of right upper quadrant pain, acute cholecystitis. There is, again, the diagnosis is just made by a combination of history, physical exam, lab test, and imaging, as stated in the 2020 World Society of Emergency Surgery guidelines. But they said, however, the best combination is not well known, and we talked in the previous video about that case of atypical acute cholecystitis to kind of demonstrate that it can be easily diagnosed sometimes, but sometimes can be a little bit challenging. So generally, again, history and exam are the most important. The pain of acute cholecystitis usually in the right upper quadrant, but could be epigastric, like in our case. It's usually it can radiate to the right shoulder or right scapula, and we talked about the reason for that. It can start as colicky abdominal pain. It usually lasts for hours, and it's usually postprandial, specifically fatty meal. Not always, but in many situations it's periprandial. It can happen at night. It can awaken the patient from sleep. It can be associated with fever, and if that happens, it's usually low-grade fever. It's commonly associated with nausea and vomiting and loss of appetite. And if you can tease out a prior episode, that would be helpful, because this is commonly seen. Patient might not offer you this information, but you have to specifically ask. Some people call this periodicity. It's a helpful historic point. Now on exam, patient might have some right upper quadrant tenderness. People talk about Murphy's sign, physical exam Murphy's sign versus sonographic or ultrasound Murphy's sign. Sonographic Murphy's sign might be more sensitive and more helpful. Patient might have jaundice, especially if there's some complications, and some local peritonitis, if it's complicated. And of course, we talked about the usefulness of ultrasound in right upper quadrant pain, so it would be a good study to start with. It can give you the diagnosis, but sometimes it can be challenging. You might need further imaging, and in that situation, guidelines suggest MRI and hide the scan. Most people will already get a CT scan. CT scan sometimes can show you the diagnosis, but not always. Again, it's a good idea to start with ultrasound and take it from there. And then liver function test. Some patients might have abnormal liver function test, but a normal liver function test does not rule out acute cholecystitis. Patient might have signs of acute inflammation, like leukocytosis and elevation of CRP. Now, coming to the left upper quadrant and left flank pain, organs to think about include the spleen, the left kidney, the stomach, splenic flexure, base of the left lung, left lower thoracic cage, and lumbar or back muscles like in the right side. And again, don't forget about the skin, the peritoneum, the soft tissue, muscles, and neurovascular bundle in that area as well before you get to the organs. Some of the pathologies that you might find there, including pyelonephritis, renal colic, and splenic pathology like rupture of the spleen or splenic hematoma. And in these situations, CT scan is probably helpful in many of these. Ultrasound also can be a good starting test for splenic pathology. In pyelonephritis, UA is needed, and of course urine culture. And in renal colic, CT, spiral CT is kind of the gold standard, because ultrasound might or might not show you the stones, but ureteral stones usually, especially small ones, seen only by CT scan. Talking about kidney stones, it's one of the most common causes of acute abdomen, really, you're gonna see. So again, really quick, the pain of kidney stone, usually in the flank, right or left, depending on the site of the stone, but it can be in the lower abdomen as well, in the groin area, and it might radiate to the genitalia, depending really on the location of the stone. Is it closer to the bladder, or is it closer to the kidneys and pelvis? So it can be variable in intensity. It's usually not colicky, although it's commonly described as that. But a lot of the patients, they actually say that the pain does not subside completely. They always have some baseline pain in that area. The worst pain ever, you probably have heard that from some of the patients, or you have seen them really struggling with the pain, crying for pain medications. It can be really, really painful if you have seen a patient with classic kidney stone. And it's also commonly associated with some nausea and some vomiting. The patient really might look really sick, and they might just writhing in pain right and left, as if they're like trying to find a position that can help them relieving their pain. Very characteristic. And then having urinary symptoms is also very common. Physical examination usually is non-specific, doesn't really add much if there is no complications. There might be some tenderness, but it's really not impressive. And then you make the diagnosis by urine analysis. It's almost always abnormal. You want to see if there's any complications like pyelonephritis on top of the stone. That's important. And then the initial test, non-contrast CT scan is the preferred initial imaging by the American Urological Association. But the European Association of Urology, they suggest to start with ultrasound. Again, ultrasound will show you proximal stones will show you there is any hydronephrosis and the structure of the kidney as well. But the non-contrast CT scan is really much more sensitive, especially for smaller stones. Now moving to another quadrant, the epigastrium, or the epigastric area, or the upper midline abdomen. Organs to think about include the lower esophagus, the stomach, the duodenum, the pancreas, the inferior wall of the myocardium of the heart, and again, don't forget the peritoneum, the skin and soft tissue, neurovascular bundle, and in that area particularly, think about the aorta and the IVC, since pathology in the upper part or of these large vessels can present as upper abdominal pain. A lot of pathologies, probably in acute abdomen, especially in the hospital, pancreatitis and peptic ulcer disease and its complications, including the duodenal perforation, might be the most common ones. Also gastritis, esophagitis, abdominal aortic aneurysm, and another common cause outside of the abdomen is myocardial infarction. And these are just some of the tests that can help you making the diagnosis, including serum lipase and CT scan for pancreatitis, abdominal X-ray, upright or decubitus views, and also CT scan with oral-soluble oral contrast for peptic ulcer disease and its complications. EGD more likely will be needed if you're suspecting esophagitis or gastritis from various causes. And then ultrasound is a good starting test for vessels, large vessels in that area, including the tubule A. But CT scan, of course, is needed for more details or to give more information. And then, of course, for myocardial infarction, you need to check ECG and cardiac enzymes to look for that. Acute pancreatitis is probably one of the most common reasons for admission to the hospital due to abdominal pain. We see it all the time, very common. Technically, we always use the revised Atlanta criteria according to the American College of Gastroenterology, the ACG, and the American Gastroenterological Association, the AGA. This is a criteria you use, which is basically you need 2 out of 3 characteristic pain of acute pancreatitis, the chemistry, including labs, specifically amylase and lipase, and then imaging. So any 2 of these, if 2 are suggestive of acute pancreatitis, you can make the diagnosis. You don't need the 3 of them. So coming to the pain, the pain of acute pancreatitis varies. It can be mild in some cases, but sometimes can be really severe. And it's usually, again, in the epigastrium area, but it can be also a little bit lower in the periumbilical area. It can be a little bit maybe in the right, closer to the right upper or right or left upper abdominal area. It might radiate to the back, it might radiate to the chest or even the flanks, but it doesn't radiate to the lower abdomen. If it's really very below the umbilicus, it's not acute pancreatitis. It's usually associated with meals, postprandial, and some patient or many patients might describe it as boring, achy pain, vague pain, usually not colicky, and it can become constant over time. Might start a little bit mild, it subside a little bit and then it comes back, but at the end of the day, most of the time it will be constant. And might last actually for days, and it's commonly associated with nausea and vomiting. It might also be associated with fever, but this is usually low-grade fever, as most causes of inflammation in the of the acute abdomen. Now, serum lipase is kind of the preferred blood test for the criteria to diagnose acute pancreatitis. You can use amylase as well, and it needs to be more than 3 times the upper limit of normal. And then CT scan, if you're still suspecting acute pancreatitis, but maybe the lipase is not impressive, but the pain is characteristic, then you can order a CT scan. If you're thinking about complications, ordering US contrast probably will give you more details, especially if you're thinking about necrosis and infective necrosis, because you need to add antibiotics in that case. There's a lot of causes of acute pancreatitis, as you know. The biliary pancreatitis is the most common one, and in that one, usually but not always, the liver function test, liver enzyme will be abnormal, and you might need to do right upper quadrant abdominal ultrasound, as we talked about in biliary disease or acute cholecystitis, because it's many times it can be more helpful than CT scan. The other common cause is alcohol, and then maybe you'll see some cases of hypertriglyceridemia, drug-induced as well, and in many cases idiopathic, as we always love to say. Now, another area that commonly involved in acute abdomen is the right and left lower quadrant. Organs to consider, including the colon, the appendix, mostly on the right side, of course, the ureters, reproductive organs for both the males and the females, and the mesenteric lymph nodes. And again, don't forget the other structure, the peritoneum, the skin and soft tissue, and neurovascular. Common diagnoses include, of course, appendicitis and diverticulitis. These are probably the two most common. And then less common but frequently encountered and important include ectopic pregnancy, appendicitis, ruptured ovarian follicle cyst, or other ovarian pathologies in general. So in these cases, mostly CT scan is needed to make the diagnosis. We'll talk about diverticulitis. Sometimes you don't need the CT scan. And remember, with pelvic organs, especially for pathology related to the female reproductive organ, pelvic ultrasound is actually very good starting diagnostic test, but also sensitive and could be specific. And a lot of times the CT scan will suggest to you to add a pelvic ultrasound to further characterize something that they found in the CT scan. So keep that in mind. Right or left, if you're thinking right or left lower quadrant, if you're thinking about pelvic organs in females, remember ultrasound. Now, acute appendicitis, really quick. It's kind of the prototype, probably one of the most common causes of acute abdomen, and the one that's usually described the most, the classic example for acute abdomen. The 2020 World Society of Emergency Surgeon guidelines, they recommended the use of appendicitis inflammatory response, or AIR, scoring system, and the adult appendicitis scoring system, the AAS scoring system, to kind of predict the possibility of acute appendicitis in patients presenting with acute abdomen. Now that gives you an idea that, acute appendicitis usually is like straightforward diagnosis, but sometimes can be really challenging. And the diagnosis is made by constellation of, symptoms and, the presence of physical exam findings and some basic inflammatory markers. So the pain of acute appendicitis usually starts classically, not always, classically described as starting as being periumbilical or in the epigastric area. And in that case, it's usually vague and crampy. It's usually like a visceral pain at that time. Then it classically is described as shifting to the right lower quadrant and intensifies over 24 hours. And that's basically because of the inflammation, regional inflammation in the peritoneum or regional peritonitis. The pain now is becoming more of somatic pain. Nausea is very common. If the patient has profuse vomiting, it suggests complications like perforation, for example, especially in patients with risk factors like elderly or very young. Commonly associated with anorexia, some textbooks describe anorexia as being almost present in 100% of cases. Acute abdomen without anorexia is not appendicitis. Some people say that. I don't know if there's strong evidence for that or not, but anorexia is common. Low-grade fever and dysuria sometimes because of the nearby inflammation of the bladder and cystitis. Again, remember, this is a classic presentation. A lot of times there could be atypical presentation in certain patient population. We're not going to get into the details of that. Tenderness is very common in physical exam. There's a lot of physical exam findings describing acute appendicitis, like the Rushing sign, the arcuated sign, Illuso's signs, and many others. Again, generally, just the tenderness is kind of the bottom of all these physical examination maneuvers, and it's mostly due to regional inflammation of the peritoneum. Now, ultrasound or POCUS is suggested to be the initial diagnostic test. It has a lot of advantages, quick and easy and no side effects, and it can give you the diagnosis. But if in doubt or if you're thinking about complications, CT abdomen with IV contrast is the diagnostic test of choice. Other diagnostic labs include elevation of the common inflammatory markers like white blood cells and CRP. Here I just want to emphasize that appendicitis sometimes can be really challenging to diagnose, and that based on the location of the appendix. And generally it's said that the only time acute appendicitis is not considered in the differential diagnosis of acute abdomen is when the patient does not have an appendix. And that's why whenever the surgeon is doing laparotomy for acute abdomen and they found the appendix not inflamed, they're looking for other cause, they usually take the appendix out so that if the patient have any other acute abdomen in the future, they know that it's not appendicitis and they start looking for other differential diagnosis. In the left side, another common cause of acute abdomen is acute diverticulitis. And kind of similar to the acute appendicitis, diagnosis is basically clinical based on the constellation of symptoms, physical exam, and basic workup. And that's also supported by the 2020 World Society of Emergency Surgery updated guidelines. So the pain of acute diverticulitis could be acute, subacute, usually constant, usually in the left lower quadrant because of the presence of the diverticuli commonly in the sigmoid and the left side of the sigmoid colon and the left side of the colon. But in some certain populations, like in Asians, sometimes the diverticuli are more present in the right side and they might have acute diverticulitis in the right lower quadrant or right abdomen, mimicking other causes of acute abdomen. It's also commonly associated with anorexia, can be associated with change in bowel movement like diarrhea or constipation, can be associated with fever sometimes, but again, it's usually a low-grade fever unless there's complications. And because of local peritonitis, tenderness is very common. And so if the patient is known to have diverticulosis, like your patient, your primary care doctor for that patient, they come in with mild symptoms suggestive of diverticulitis, you can just treat it empirically with antibiotics and send the patient home if there is no concerning symptoms or physical exam findings or vital signs. But if the patient is not known to have diverticulosis, then you want to look for the diagnosis. Of course, CT scan with contrast is the kind of imaging modality of choice, and also look for complications. Basic workup, as expected, include elevation of the white blood cells and also other inflammatory markers like CRP. Now coming to the lower abdomen or the suprapubic area, organs to think about include the bladder, the distal uterus, the distal 2/3 of the colon, especially the sigmoid colon and the rectum, and then the pelvic genitourinary organs, and of course the peritoneum, skin and soft tissue infection, neurovascular bundle in that area. Common conditions you're going to encounter as a cause of abdominal pain include UTI and cystitis, pelvic inflammatory disease or PID, tubo-ovarian abscess or other ovarian disease like torsion of the ovaries, ectopic pregnancy, and endometriosis. And these are just some of the imaging tests. Again, CT scan is helpful in many of the situations, but ultrasound actually can be even more helpful in a lot of these pelvic organs. Now, commonly the abdominal pain could be diffuse or very variable. The patient might not give you a direct location for their pain. It could be like almost everywhere. That's not uncommon. Actually, a lot of the common causes of abdominal pain or acute abdomen, many of the times describe it being diffuse or variable in location. So common examples include the gastroenteritis, intestinal obstruction or bowel obstruction, volvulus and intestinal strangulation, intestinal perforation, ischemic colitis, mesenteric ischemia, inflammatory bowel disease, retroperitoneal hemorrhage, mesenteric thrombosis, and abdominal aortic aneurysm rupture. So these are relatively very common, and luckily a lot of these pathologies actually can be seen on imaging, including the CT scan with or without contrast, or with IV contrast or oral contrast. So you really have to think about what are you looking for based on the history and physical examination to get the right test to order. But again, the good thing about these common pathologies is that most of the time most of imaging will give you some clue about what could be the underlying cause. But that should be guided by careful history and physical examination. Also, don't forget about abdominal wall disease. These are relatively common. Some of the times it could be asymptomatic. The patient might not have a lot of symptom, but in other situations they can present with some abdominal pain or tenderness. Now, these include hernia, trauma or hematoma, or tumors and masses. Okay, really quick, in the next few slides, we're going to talk about a little bit less common and rare causes of acute abdominal pain. Luckily, most of these causes can actually be revealed by imaging. So you're not really expected to, remember all of them by the time the patient is coming with abdominal pain, right? But imaging usually will suggest a diagnosis for you. One of these conditions is called Epiploic appendagitis. It's basically inflammation of the epiploic appendices. These are the epiploic appendices. They're really just small mobile pouches of the peritoneum. They're usually filled with fat, and they're usually situated parallel to the outer surface of the tenecoli or the colon. And these sometimes when they get thrombosed or they get some torsion and ischemic changes and inflammation, they can cause abdominal pain, and it's called epiploic appendagitis. Clinically, it's usually seen in obese patients, usually men between the age of 30 and 50. The pain is usually presents acutely as focal lower quadrant abdominal pain and tenderness, either in the right side or the left side, depending on which epiploic appendices are inflamed. Usually, the peritoneum is not that involved, so there's usually no significant guarding or rigidity. It might be associated with postprandial fullness and epigastric discomfort. We don't know exactly why. As you can expect, some fever, nausea, vomiting, non-specific GI symptoms, diarrhea can happen. Not very common, but they can happen. And you expect some leukocytosis as well. And based on the where these appendices are situated, the differential will include organs in that area. Common ones, of course, appendicitis, diverticulitis, bowel ischemia, PID, uterine stones, cancer, gastritis, or enteritis. Again, based on the location, and we talked about these much more common pathologies and how to work them up. Now, a CT scan, luckily, is kind of preferred imaging modality, and most of the time, if there is clear inflammation, it will show up there. You can use MRI as well if the CT scan is suggestive but not conclusive, and many include supportive care, antibiotics, for a few weeks, and then in rare situations when some patients do not respond to the supportive treatment, then you need surgery. Another less common cause of abdominal pain, acute or chronic, is chronic inflammation and fibrosis of adipose tissue, which is called mesenteric panniculitis, and it usually happens in the adipose tissue of the small bowel mesentery. So this is usually asymptomatic, meaning it could be just incidental finding, but it can cause some non-specific abdominal symptoms. Luckily, it has generally benign course. Clinically, this condition is most commonly seen in white males aged 50 to 70 years. Again, it can present acutely, subacutely, or chronically with some chronic abdominal pain or discomfort. Some other GI symptoms include early satiety, anorexia, weight loss, bloating, nausea or vomiting, diarrhea or constipation. And interestingly, it can be one of the causes of fever of unknown origin. Patient might have inflammatory symptoms like chills, weakness, and intermittent fever. Now, the diagnosis, luckily, again, CT scan can show the features of mesenteric panniculitis. It can be seen as a mass-like area of increased fat attenuation within the small bowel mesentery. Some people call this the misty mesentery. and it's usually located in the left upper quadrant, but it can be in any part of the small bowel mesentery. It can mimic lymphoma or other tumors because it looks like a mass. Confirmation is needed by histology and biopsy, usually done by laparoscopic procedure of the mesentery, and that will show the mesenteric fat inflammation. Treatment, most of the case, again, depending on the severity of the symptoms, follow-up might be appropriate. You can try anti-inflammatory like prednisone, tamoxifen. In rare situations, surgery might be needed if the patient is having complications like recurrent bowel obstruction. Another interesting entity is Chilaiditi sign, which is basically the presence of air below the right hemidiaphragm on imaging, and that's due to colon interposition, not because of bowel perforation or air in the abdominal cavity where air is not supposed to be. It's actually, in this case, air is supposed to be in its position, where is it within the colon, but the problem is the colon is actually sitting between the right hemidiaphragm and the liver. This is called a Chilaiditi sign, and it's usually incidental finding. Most of the patients are actually asymptomatic, but in case of symptoms where people call it Chilaiditi syndrome, patient might have abdominal pain, discomfort, sometimes even some respiratory symptoms as well. Rarely can cause some complications like bowel obstruction and perforation in some case reports. And of course, the most important differential diagnosis is pneumoperitoneum and subphrenic abscess, other more serious pathology in that area. But usually, if you look carefully at the air in that area, usually you can see the normal plicae circularis or the haustral markings of the colon under the diaphragm, instead of the just pure black or pure air in that area. And also, if you change the position of the patient, this will not change the finding of air, but that will change if the patient is having free air from more serious condition. And of course, if the diagnosis is still not clear, you can always get a CT scan where it can really show that this is just part of the colon, more commonly the hepatic flexure in that situation. All right, so yeah, this is quickly some of the less common causes of abdominal pain. But again, in most of the situations, CT scan and imaging will give you the diagnosis. In the next coming videos, we're going to talk about when this imaging is not really revealing or non-specific or didn't give you the final diagnosis. There's certain conditions, diseases that might be a little bit challenging to diagnose without imaging. So we're going to talk about that in the next videos, so stay tuned.